And no one wanted to talk to me about dying, not my physicians, not my family. And so that was something I had to handle on my own. And I did. And in going through that process, I found that it made it easier for me to then talk with patients who were going through difficulties themselves. Not to say, oh yeah, I know how it is because I've been there too, but just to be at home in the space that they were in and to be able to stay with the conversation because I wasn't afraid of it. So that led to me becoming a hospice medical director part-time in 1988. And over time, hospice and palliative medicine became more and more of my life. And of course, compassion is such a strong component of that care as well. As we've been hearing all morning about the importance of dealing with the whole person and hospice and palliative medicine's ability to really understand the patient's experience. So that reinforced that initial interest I had in how we care for the whole person. But after about 5 years of doing hospice, I felt that I was completely depleted. I felt that, I had just given, and there was so much suffering that I could not address. So much suffering that our medical system did not have the tools to resolve. And it was pulling me down. And Martha mentioned the burnout rate among physicians, and I felt like I was going down that path, that I just couldn't do this for the rest of my career. And that's when I found the third strand in my river of movement toward compassion, and that was taking a course called Contemplative End-of-Life Care. And I did that in the year 2003-04. It was the first year that that course was offered, and the main teacher was a woman named Christine Longacre, who wrote a book called Facing Death and Finding Hope. And Christine's story was actually much like Valerie's. Her husband had died when he was in his 20s, and she realized all of the difficulties that they went through. And she became a student of Sogyal Rinpoche, a Tibetan Buddhist teacher who wrote the Tibetan Book of Living and Dying. So over the last 30 years, Christine has developed trainings for medical professionals under a program called Spiritual Care, and I've had the pleasure of being faculty for those programs for about the past 10 years. So it's allowed me to not only find ways to nourish myself and find tools that I could directly bring to the bedside that helped me with that sense of I just don't have any more to give. But it's also helped me to feel more at peace with what's going on, even those things that I couldn't control, that ambiguity that we have to stay in the middle of. So that's how I got here. And of course, I've had many other wise people who've helped me understand patients and families above all, but also philosophers and spiritual teachers and mentors and people who lead this field, like some of the people who are here with us today. Okay, now I forgot to ask which button. I'll try this one. No. Try this one. Okay, it worked. Okay. So I hope to convince you of these 3 points before we're done, that when we practice compassion, it helps us as much as it helps others. It's not selfish. The Christian saying is, love thy neighbor as you love thyself. And if you don't love yourself, well then, poor neighbor. I also hope to convince you that we can't do compassion unless we really begin with that self-compassion. And that although we all have compassion within us, it is a capacity that can be increased and we can train through practice so that we can do it better and have more of it. So there are a number of definitions for compassion. I was going to ask you, but I'll just tell you what's on the slide because you know that. So it's a feeling. It's a feeling of connecting with the suffering of another, but also a desire to help. It's a feeling and an action. It is emotional and cognitive at the same time. We all have it. It's always in us. So if we're walking across a parking lot and we find a crying 2-year-old out there by themselves, we will naturally try to help that child. If one of our loved ones is suffering, we will naturally try to help that person. There's studies that even show if people who root for the same sports teams that you do are suffering, you're more likely to help them than if they root for the opponents. So the more people are like us, the easier it is, but we can build that capacity. And for many of us, it was why we came to medicine. It's why we wanted to be doctors, nurses, social workers, chaplains, because we wanted to help people. We wanted to care for them. And as we've heard already this morning, sometimes that wish has been blunted by our system. Okay, now what happened? Oh, okay. So this is a beautiful picture of a woman named Sheila by a photographer, Jack Radcliffe. And you don't even have to know Sheila's story or her medical history to imagine that she is suffering in some ways. So in looking at her picture, tell me some of the things that come to mind, that in ways in which she might be suffering. And I'll repeat them into the microphone. Clay. She's exhausted in many different ways, not just physically. What else? Lonely. She seems to be isolated. Scared. She seems to have a real grip on that rail as if she's holding on for dear life. She does have nail polish on. Myra once said she must have her makeup on even in her grave. But yeah, the changes in appearance and how that can certainly cause suffering. Not only is it about being able to keep up your hair just so. Of course, in the hospital we can't dress just so like we usually do, and she's probably lost a lot of weight to look at her, and so that whole change, from maybe somebody who thought she was kind of hot to, somebody who looks sick, that's pretty tough. Anything else that comes to mind? Anxiety. What might she worry about? Her family. That's a big, big one. What? The finances. A lot of bills that aren't covered by insurance, as we know. Yeah, so she's young enough, she may have children that she's leaving, or maybe she wasn't able to have children the way she wanted. Speaking of anxiety, I heard recently, I don't know the source of this, but I was told that research has shown that 80% of the things we worry about never come to pass. So we waste a lot of energy in anxiety, but obviously in a situation like this, you would have that. Another big loss for most patients like her is her loss of independence. As we get weaker, then we can't do for ourselves, and that makes us furious. We mentioned the isolation. She may be not able to participate in family events. in gatherings, in going shopping with her friends, or whatever it is that she would like to enjoy, or in her spiritual life. Is she able to attend church or be with her church community? There's so many ways that people are isolated. And from what I consider a spiritual perspective, she may be asking those big questions of meaning. Why is this thing happening to me? Did I do something to deserve it? Or what has my life been worth? If I'm dying this young, how will I be remembered? How will people judge me? So being a minority in the healthcare system can mean that there are feelings of even deeper isolation or not receiving the same level of care or consideration, perhaps, or of, inadequate social supports or other things that may have affected her because of that ethnic status. And there may be also some questions with God, like, how could God let this happen to me? Or where's God when I need him? So that feeling of not being connected. And just quickly, how might her clinicians be suffering? How about the people who are taking care of her? A feeling of helplessness, feeling inadequate, that we can't give her the life back that she used to have. We can't cure her. But I think there's also feelings of inadequacy even when we know that we can't cure her. And I think that was part of my suffering as a clinician, that she had so much suffering that I couldn't do anything about, or I didn't know how to do anything about. So we've all experienced in our professional lives many patients like this, and the broad array of suffering that comes when you are a patient. For me, there were two big ones. There were many that I learned, but two big ones in the first few months of my treatment. I mentioned infertility as a big one, and the day my hair fell out, which happened about 2 weeks after my first chemo. That was the day I could no longer pretend that this wasn't happening, and it was devastating. And I had to buy a wig that day, and that was another whole terrible experience. They were all so wiggy. Michael Carney is a wonderful palliative physician and author, and this is from his book, A Place of Healing, and he talks about the patient's experience of illness. There are some parts of it that do respond to our medical intervention, and some that do not. And for instance, much of physical pain we have tools for. The center's done a lot of work on making sure that we're doing good pain management. But there are many other types of suffering that we don't have good medical tools for. And Carney goes on to point out that some of the physical pain doesn't respond to the medical tools, and some of the other types of suffering may. So there's always an overlap. And it's that part that we don't have the tools to treat that we've had the struggle with, I think. Some of the conversation this morning reminded me also of one more thing that Michael Carney said that I've always loved. He said, our job is not to find the answers for people. Our job is to create a safe place where they can find their own answers. And some of the conversation we had this morning really touched on that. So why don't we do a good job with compassion in our healthcare system? We've been talking about the system, all of us. What gets in the way? We've already touched on some of them. What came up, or what comes up in your mind? What? The technology. And technology orders our thinking, and I think we've already touched on that. But, there's nowhere in the medical record now that we have electronic medical records, and that wasn't there when we were writing soap notes by hand, There's no place to put in there what's the most important to this patient. What is the patient hoping for? What are the families struggling with? It's not in the system. And so an electronic medical record pushes us to think inside the boxes that we need to answer. And so there's issues of us spending time with the computer, making sure we document everything, but it's also an issue of how it orders our thinking. What else? Yeah. Yeah, so Myra's saying, John's going to get a microphone, but Myra's saying that sometimes those of us who are providers are not as empathetic as we could be because we don't have as much connection with people who are different racial groups, socioeconomic groups, cultural groups, immigrants. And we live in a society where we're ever more stratified, and we actually have less contact with people outside our group, unfortunately.
Physicians, we now see that we have fewer African American men applying to medical school than we have had in 20 years. So the disparities between the provider and the patient is actually increasing instead of decreasing.
Okay. And you think about other cultures, such as prisoners, veterans. I mentioned the immigrants, substance abusers. We as providers are usually not part of those communities and don't understand. Yeah. Yeah.
So many cultural barriers to understanding different groups, whether they be African American or Latino. It's very difficult for physicians to understand where patients are coming from, where their families are coming from, and I think there is sometimes a lot of distrust, and it's hard to forge those barriers. Very, very difficult, and I don't know what the answer is, because we have patients that come from all over the world, basically, and I know that their anticipation of what a physician does is different from group to group. And how do we do that? How do we navigate that territory?
Yeah. To keep us, you want to say something, Martha?
I actually think one of the biggest barriers we have is tyranny of the urgent, which has gotten worse. I liked her slide of mindful versus mindful.
Right.
And the fact that we are so time sensitive, but we're wasting so much time.
Right. So that time pressure, that sense that we're under such pressure. I'm John, I'm not going to take any more comments because I'm falling behind here. So thank you. Some of the other barriers to us providing compassion might be that fear that we'll get into an emotional discussion, that I don't have the time to continue, or I don't feel equipped to continue right now. And this whole model that focuses on evidence-based medicine, randomized controlled studies, pathophysiology, and not the whole person. And just the, our own stresses, our own distress, our own burnout, our own feeling that I can't take one more thing makes it hard for us to offer anything to anybody else. So what is not compassion? We've talked about what compassion is, so we can contrast that with pity and with empathy. Stephen Levine, a wonderful author, has said, when your fear touches someone's suffering, that is pity. When your love touches someone's suffering, that is compassion. So pity is when we distance ourselves from the suffering. We avoid it. And empathy is the feeling with. It's feeling how this person is feeling, imagining how it is for them. But if we stop at empathy, it can lead us to burnout. So here's a little way to look at it. Imagine you're walking along, and there's a big hole in the ground, and you hear a voice down in the hole. And you look, and there's someone in great distress who's fallen into the hole, can't get themselves up, can't climb out. And if you're feeling pity for them, you say, "Oh, poor you. It's too bad you've fallen into that hole." If you're feeling empathy for that same person, you might say, "Oh, poor you. Let me come down there and help you." And now you're both down in the hole. And if you're feeling compassion, you might say, "Oh, this is terrible. I'm going to come down here and find a way to get you up and out of this hole." Oops. One of the things that we need to remember is that even the witnessing of suffering is a true experience of suffering. So all of us suffer vicariously, secondarily, by witnessing the suffering around us. Tanya Singer and her colleagues at the Max Planck Institute in Germany have written a lot about compassion and done studies. And here's how they divide that empathy and compassion. They said with empathy, we have that empathetic distress. We feel the pain, and it leads to negativity and causes us to pull back. And with compassion, again, we are aware of the emotions, but our feeling is more positive because we're going to do something about it. We're going to try to resolve that situation. So it helps us have more to work with. It helps us avoid being drained. As we know, this is not a new topic, and we already heard from Martha the Francis Peabody quote. I'm going to share with you a little more that he wrote in that article in 1927 because it seems so current. He wrote, "The most common criticism made at present by other practitioners is that young graduates have been taught a great deal about the mechanism of disease, but very little about the practice of medicine. Or to put it more bluntly, they are too scientific and do not know how to take care of patients." 1927. So even before we got into the wild deaths that Richard talked about, that complaint was already being raised. Now, there are some scientists who are doing research on compassion and how it works on us, and they're often using things like functional MRIs to see what areas of our brain are active when we're practicing compassion. Some of the studies have been done, like Dr. Richie Zavison up at University of Wisconsin started his studies looking at Tibetan monks who'd been meditating on compassion for years. And he found that areas of the brain that are most associated with happiness, love, and positive emotions are lit up when people are meditating on compassion. But not only that, they stay lit up when they're not meditating. We know from neuroplasticity that the brain continually develops new connections, and areas that we use a lot are more active than areas that we don't use a lot. So, as Sogyal Rinpoche says, it's like permanent brain damage. They're always happy. The areas involved in anger and other negative emotions are less active. There's also been studies looking at the autonomic nervous system. So the sympathetic nervous system is the fight or flight. You get a lot of stress hormones released, blood pressure goes up, heart rate goes up, breathing rate goes up, you start sweating. Those are things that happen when we feel we're under stress, while the parasympathetic nervous system tends to calm us. And practicing compassion actually leads to more activation in the parasympathetic nervous system, so we are calmer. And we also may have release of oxytocin, which some people have called the love hormone. It makes us feel more pro-social, more wanting to engage with others. It's the hormone that's released when a mother looks at her baby. And recently we found when you look at your pet dog, it's also released in both you and the dog. And grandmothers, oh, yeah. So in internal physiologic ways, in changes in our brain, we can see that compassion helps us. I love this statistic. I don't know the original study, but I read that mortality risk is reduced 50 to 91%, or 3 times more than the effect of physical exercise. I'm all for that. And I've said that compassion is empathy plus reason. We're not just feeling, I feel your pain, man. We're analyzing. We are thinking about what's true for me, what's true for this person, what can be done about this situation, so that we are no longer feeling that we need to be overwhelmed by it. Nelson Mandela said, "A good head and a good heart are a formidable combination." So how do we practice compassion? Well, we begin with ourselves. And we've heard about mindfulness, and Valerie talked about it this morning, about being present, about really paying attention. I had to laugh the other night. The New York Times had an article, I don't know, over the weekend, I guess, about not multitasking, about paying attention. So it was a very interesting article, and I looked around the room. I was down at my dad's. So Dad had his newspaper and was watching the football draft on TV. I was reading the article on my phone and, kind of listening to the conversation in the room and trying not to pay attention to the draft. My sister-in-law was doing her embroidery and participating in the conversation. My brother had his crossword puzzle and was watching the football draft and also talking with us. So we're all so skilled at multitasking, but really what we're trying to do here is learn how to pay attention, learn how to be present. And we'll talk some about ways that we can do that. Other things that we need to do to practice compassion is that we have to have a motivation to help others. We can set a motivation for our day, and one of my favorites is, may I relieve suffering. And my best favorite is, for everyone whose lives I touch today, may I make it a better day rather than a worse day for them. And we can do that. We can do it on the fly. We can do it in the moment when we get on the elevator with people. How we interact with them can make their day better or worse. And we need to keep practicing this. We can't bring mindfulness to a tense family meeting or other difficult patient encounter unless we have practiced it when it wasn't so distressing or tense. So a daily practice is very helpful so you have something to bring into those situations. So when we practice self-compassion, we are taking care of ourselves. If you had a friend who said, classic medical student thing, "Oh, I really screwed up on rounds. I didn't have the answer to the professor's question. He was teaching by terror. And, I'm no good at this. I don't think I'm ever going to be a doctor." Would you say to your friend, "Yeah, you're stupid. You finally figured it out"? But we say that to ourselves all the time. We just do the criticism. We don't comfort ourselves. We don't put that metaphorical arm around our shoulders like we would a friend's shoulder and say, you did the best you could. It's only one mistake. You're doing so much other good stuff. We don't think of doing that for ourselves because we're so self-critical, especially in this society. So just to have self-compassion is to engage in internal dialogue that's more benevolent, more encouraging to ourselves. And to recognize that, it's not the other people that are all having perfect lives with no problems. We are all flawed human beings. We all make mistakes. We all have difficulties and conflicts. As I've said, this is not selfish. It's not about I just want to take care of me and not care about anybody else, because I can't take care of anybody else if I'm not taking care of me. And at the same time, it's not sugarcoating, it's not pretending that the bad stuff is not happening. It's really courageous, because I'm looking directly at the bad stuff and saying, what can I do with that? How can I take care of myself in the face of all of that? I think I've said most of this. But just to reiterate, we can stand up to the harm we tend to inflict on ourselves. We can be aware of it first, and we can treat ourselves with the same kindness that we would someone else. And it takes that mindfulness, it takes that noticing when we're doing it. It takes noticing what's going on. One way to notice what's going on is to pay attention to your physical sensations. Physical sensations always happen in the moment. If you're having a pain now, that's in this moment. If you take some deep breaths, that not only brings you into your body at this moment, but it also activates your parasympathetic nervous system. So that is a way of calming ourselves. Paying attention to our bodily responses can help us understand what's going on in this situation. My gut is really tightening up whenever that daughter speaks in this family meeting. Can help us understand what's the dynamic here. Or I just feel so depressed. Somebody here is depressed, and it may not be me. That's supposed to be one of the key indicators for recognizing depression is if this person makes me feel depressed. So, am I feeling slumped over? Am I feeling energetic? What's my posture? Am I feeling driven? I have to walk down the hall so fast because I got so many things to do. What if I slow down and straighten up and look out the window as I go by? All those things change us, but that's awareness in the moment of what's happening. And it also helps if we can have a feeling of spaciousness, because we tend to tighten and tighten and tighten. Sometimes my head almost hurts from like the muscles are tightening up. There is more space than that. If you put your hand right over your eyes, you can't see a thing. But if you put it out here, you can see a lot of other things. So can I put that problem over here and see some of the other things that are around besides this one thing that I'm blocking myself with? And we can have some humor about it. You say, oh, there you go again. Well, that's okay. We can laugh at ourselves. Now, that takes skill, that takes practice too, but it can be quite helpful. If we practice compassion, we are more pro-social. We are more engaged with other people. We feel more love, more joy, all those positive emotions, more contentment. What a gift that is. Less anxiety. Our physical health is better. As we've talked about, if your cortisol levels are not as high, then your blood pressure is not as high. Your immune system works better. There are many ways that it affects us. So it creates this upward spiral. The more you do, the better you feel. The more you want to do, the better you feel. It just keeps going up and up. We don't do it well if we are trying to protect ourselves, if we're putting up barriers. If we're saying, I can't get into that conversation because, this person's her situation reminds me of my own grief about my family loss, and I can't go there because it's too scary. Or for many of us, even physicians and nurses who practice hospice, I can't talk about death and dying with that person because it will touch too close to my own fear of dying. So the more we put up the barriers, actually, the more we're trying to control and the more pain we have because it's uncontrollable. Hardening our heart against the fear of dying does not treat the fear of dying, just as chemotherapy does not treat a fear of dying. we need to find a way through that fear. Or we may be always looking for threats. This person is going to take too much of my time. That daughter, she gets on the internet and she always has 50 questions for me. We see people as, problems for us instead of someone that we want to engage with. And sometimes we're making it all about us. Oh, they think I'm a really good doctor. Or we're afraid they're going to blame us. I've had people say to me, "You're the least caring physician I ever met." Now that is a button. But I eventually learned it's not true, So I don't have to take their blame. It may be true for them. It's not true for me. But if I'm making the conversation about, am I doing a good job or am I doing a bad job, then I'm missing the whole boat. And sometimes we repeat the litany of our own misery. I learned this by seeing how I was doing on the days when I felt real busy. I just walk around with this theme of, I've got too much to do, I've got too much to do, I've got too much to do, which never got a darn thing done, and it made me more miserable. And if I just dropped it, then I found I got more done, and I was much happier in the process. It doesn't help if we say to people, "I know how you feel," because we heard the importance of narrative, and none of us has been in their story. We may have had some somewhat similar experiences, but we have not had their lives. It doesn't help if we say, at least, your daughter's dying, but at least you have a good son. Which is a variant of, it could be worse. You're losing your grandchild, but at least, it could be worse. You could have lost 4 of them in an accident. And also one of my favorites, the day I was actually told I had cancer, my lovely medical partner was the one who took it upon himself to come in and tell me I was alone in the hospital bed after surgery, and he was holding my hand and doing his best to give the news gently, and I started crying. And he said, "Don't cry." It just didn't help. You know that. So it's really not just about what we say. It's not about the phrases that we pull out. It's about how we are. How we are can make patients feel more comfortable, safer, more at ease from the moment we walk into the room. So how are we? Am I feeling stressed? Am I feeling tense? Am I frightened? Or am I feeling calm, centered? Am I feeling that I want to find out what's going on with this person? Do I have the curiosity to know what is going on with them? And that can lead to more trust and the ability to communicate authentically, to really be present. That's what I want to do. To leave all the other stuff that I got to worry about this afternoon out in the hall, be present with this patient and family until I move on to the next one. And like I said, it's not necessarily about taking more time, but it's about being there while we're there. So I'm going to skip ahead because I want to share with you a tool, and if I do this, we've got enough time to do it. And the tool is the practice of metta, or loving kindness. Are some of you familiar with that? A few. Yay, Martha. So loving kindness is a practice that was originally taught by the Buddha. And the story is about how it was originally taught. Now, remember, this is 2,500 years ago. The Buddha had a group of monks that he sent to meditate in a particular forest. And the monks sat down and tried to get peaceful and meditate, but there were evil tree spirits there. And the spirits were bothering them and harassing them, and they couldn't settle and meditate. And in fact, the spirits drove them out of the forest, and the monks went back to the Buddha and said, we can't go there. Please send us somewhere else to meditate. And he said, no, I know the problem with the tree spirits, but here's a way that you can manage them. And he taught them this practice. Now, in 21st century America, most of us don't believe in tree spirits. But we still have internal demons. We still have internal voices that are pestering us, interfering with our ability to be present, to be loving. And so this is a way to calm those down. And in fact, when the monks practiced this very simple practice with the tree spirits, they found that the spirits became loving and actually were helping them. So maybe your demons can learn to help you as well. So I'd like to just run it through. Let us experience it once. So it might be helpful if you would put down whatever you're holding and maybe kind of sit up straight with your limbs uncrossed, kind of just comfortable in your body. And you might want to close your eyes for a bit. And maybe just notice your breathing without altering it. And notice how your body is feeling in this moment. And then recall a time when you really felt cared for or unconditionally loved. Maybe not romantic love, but maybe the love of a grandparent or parent or a pet. Just a time, maybe a moment in that relationship when you felt that you really were cared for just as you were, completely accepted and loved. And allow that feeling of loving kindness to just warm your heart and fill your whole being like warm rays of sunlight, so that we feel comfortable and well. And you can silently repeat to yourself these phrases: may I be happy. May I be well. And continue silently repeating, may I be happy. May I be well. And again, from that memory of loving kindness, consider that this radiant loving kindness flows into us and melts any difficult feelings, such as anger, fear, anxiety, jealousy, or self-judgment. As we continue to repeat the phrases, may I be happy. May I be well. We can imagine being free from fear and from any danger, either internal or external danger. And as we repeat the phrases, may I be happy, may I be well, we may want to add, may I be safe. And if we become aware of any difficult thoughts or aspects of ourselves that we judge or reject, we can simply acknowledge them with acceptance and extend loving kindness to those aspects of ourselves as well, saying to those parts of ourselves, may you be happy, may you be well. And recall a time when we were more in touch with our fundamental goodness, that essence within us, when we were able to show compassion, loving kindness, or selfless generosity to another person. Allow that memory to dissolve any feelings of unworthiness and realize we are worthy of receiving loving kindness. Remembering that our fundamental essence is naturally loving, as we continue to repeat, may I be happy, may I be well. We may even feel a sense of joy in truly wishing ourselves to be well and to have loving kindness. So spend a moment imagining that you are really happy, really well, as you continue to repeat, may I be happy, may I be well. And as we conclude, you can gently let go of repeating the phrases and just rest for a moment in that feeling or atmosphere of loving kindness. And as we end this, we can dedicate this practice toward our own happiness and toward the happiness of all those who we care for, and in fact, all beings. You can open your eyes and come back. So that is the practice of metta, M-E-T-T-A, Sanskrit name, or loving kindness. There's much written about it. There's studies done that show that you should practice it for yourself. But if you do it for 7 weeks, you'll have more positive emotions, more mindfulness, better vagal tone. That's a sign of parasympathetic nervous system, better mental and physical health. So it's a very worthwhile practice. It's recommended that if you do take it on, that you do it for yourself for several weeks before you try to apply it to other people. But because the practice is so simple, you can apply it in all sorts of situations. You know, when you're on the freeway, I drove 30 miles on the freeway to get to work, 4:35. And so you're on the freeway and traffic is congested, and there's some guy riding your tail, wants you to go faster, and then he cuts around you and cuts in real fast. And, you know, my usual reaction was to get angry with him, right? Because it was dangerous and frightening. But if I catch myself doing that and say to him, he doesn't know what I'm thinking about him anyway. If I say to him, may you be happy, may you be well, may you be safe. That's a different feeling that it leaves me with than if I say, you idiot, you almost made me have a wreck. And by the time I get to work, I'm still angry at him. And my whole day is ruined, or at least for a few hours. But if I give it up, if I wish him well, it transforms the whole thing. None of my thoughts have any impact on him at all, but it has a huge impact on me. So Dr. Robin Youngson said, every act of compassion is also an act of self-healing. The pain of witnessing suffering and loss is ameliorated by the deep satisfaction of knowing that your caring makes a huge difference to the patient. In the end, we are all imperfect and vulnerable. So I'm going back to my 3 main points. Helping helps you. Practicing compassion is good for us. We need to practice compassion for ourselves first. If we cannot love ourselves, we cannot love someone else. And we can increase our capacity for compassion by practicing until it is our habit, our motivational drive, and what carries us through each day. So I'll finish with some words from Mother Teresa. She said, we all long for heaven where God is, but we have it in our power to be with him in heaven at this very moment. But being happy with him now means loving as he loves, helping as he helps, giving as he gives, serving as he serves, rescuing as he rescues, being with him 24 hours, touching him in his distressing disguise. Thank you.